Our next presenter is Ellen Fremion. She is an MD with a combined training in internal medicine, pediatric physician at Baylor College of Medicine Transition Medicine Clinic, a primary care medical home for adults with intellectual abilities and developmental disabilities with complex medical care needs who have transitioned from pediatric care. She is also the founder and program director for the Texas Children's Spina Bifida Transition Clinic, which prepares adolescents with spina bifida for transitioning to adult care and life via comprehensive care planning, care coordination, and self-management goal setting. She has developed a peer mentorship program in which individuals with intellectual developmental disabilities mentor their peers on how to navigate adult health care and independent living. She is also a clinical educator teaching medical students and residents how to care for adults with intellectual developmental disabilities and their transition to adult health care needs. She also enjoys being a wife, a mom to 3 wonderful boys, and a Sunday school teacher. Please welcome Dr. Fremion.
Glad to be with everybody today. I'm coming to you from Houston. And my talk today is going to be around the transition between pediatric and adult care. It will not be Mowat-Wilson syndrome specific, but I think that it will be relevant to a lot of families and physicians here. I'm also not going to be specific to any state. So for those of us in the United States, the varying support structures and how things work varies from city to city, varies from state to state. So I'm going to talk in generalities today. A little background, here's what our team looks like. We have nurses, we have social workers and physicians accustomed to taking care of young adults with intellectual and developmental disabilities. And this is our clinic here in the foreground in Houston, and just a percentage of the patient population that we see. So a diverse group from autism, cerebral palsy, Down syndrome, spina bifida, and other genetic syndromes. So today we're going to learn how to develop a transition plan from pediatric to adult care for an individual with an intellectual or developmental disability. We're going to review some of the resources that facilitate transition planning throughout life. So it's never too early to plan. You certainly want to enjoy today, but thinking ahead is a great thing to do as well throughout the lifespan. And then we're going to talk a little bit about some opportunities to facilitate individual and family wellness in this transition process. As all transitions go, transition from pediatric to adult care can be very stressful and changing a lot of things all at once. All right, so some of the preliminary work oftentimes looks grim from all these studies. So here is some of the take-home points from a study that asked parents about their transition experience. So number one, they noted that there are very poor interactions between medical, educational, community, and vocational systems. And I would add something particularly for the medical interaction, that there is a lot of disconnect between pediatric and adult providers, as I kind of bridge both sectors, even in my own relatively joined experience, that there's still a lot of disconnect there. There's also a disconnect between payers, so insurance companies, other supports within the community as well. Sometimes families feel like they're left out there floundering in adulthood with inadequate supports, and they don't know exactly where to turn because they've lost their school system, they've lost the pediatric people that they loved. So that's a very grim picture, but they also have a lot of hope, and despite all of this uncertainty. So if everybody remembers the movie Apollo 13, where the engineers had to try to fit these two filters together, one was square and one was round, they said, we need to fit this into this. And sometimes the transition between pediatric care and adult care can often feel like this for patients and families as well as doctors. Things don't match up quite the same about who's going to be doing what. Sometimes the conditions are unfamiliar to adult doctors. So there's a variety of things that we have to make fit together for a smooth transition. So these are some of the things to consider when preparing for adult healthcare. So we're going to talk a little bit about how does your new doctor get to know you well. It may feel like you've explained the diagnosis and their needs several different times, and here it comes again. So we're going to talk about a good way to do that, how to build a medical summary that has all the things that your loved one needs, and so they transition between doctors, how to look for funding supports and understand some of those changes, decision supports, care coordination, and how to think about where they're going to live as adults. So first, here are some questions that you could answer, ask yourself in order to prepare a get to know you page. And then I've given an example from Sophie Goldstein. Her mom allowed me to use her summary about what they love about her, what are important to her, and specifically for doctors, what best supports a positive doctor experience. In my experience, a lot of young adults that have intellectual and developmental disabilities have been traumatized, unfortunately, by some of the medical care necessary that they have received in the past. So they've been held down for blood draws or shots. Going to the doctor's office is a very scary experience. And now that they're grown-up size, it's very difficult to get things done when you can't hold them down. And that's not the ideal way to treat anybody anyway. So we spend a lot of time talking about what the doctor visit looks like. We also try to see our patients every 3 months, even if they're not that medically complex. There may be some social complexities or emotional complexities, and it's helpful for us to get to know them. In addition, they get really comfortable coming to see us. They realize that that is a familiar place to them, that it's a place where people are trying to help them. And so that way, when they really have a concern, number one, we can detect that difference in their behavior or other changes. And two, they're much more willing to let us help them to figure out what's going on when they are sick. So we really encourage that regular follow-up. And the other thing I tell families on the first visit is that emergencies are emergencies and non-emergencies are not emergencies. So if a blood draw to check for just screening labs is not really indicated that day, or it can wait, and the patient is nervous, or it's been a long time with that first visit, then we can do that a different time and we can walk them through, or just say, why don't you go look at the lab, shake hands with everybody, get to know a familiar face, and we can make that less traumatic for them in the future. Here's an example of a medical summary. So again, it just lists what we would think: the medications, allergies, supplies, equipment is very important, and what maybe the last date of the new equipment, because that helps us with some of the regulations with insurance, current diagnoses and conditions. And you also want to include here who manages those conditions, who's the prescriber of the medications, so that we can have a clear plan as we transition those things from a pediatrician model to an adult care model. Also, understanding what major hospitalizations there were. Sometimes on the adult side, we can't see all of the pediatric healthcare records, so we may not understand what leads this person to go into the hospital. And sometimes there's things that are modifiable. For example, there's many patients that go to the hospital due to aspiration pneumonia. And if we know that information, then we can talk about a respiratory therapy or ways to prevent that, or look at the feeding situation to try to prevent some of those hospitalizations. And then you can see the other things here listed. This is an example of a condition medical summary, because sometimes you feel like, well, I could go on forever. They've had this condition forever. There's been multiple exacerbations. You know, what all is important for me to list? So just a brief summary, maybe the onset, for seizures, the type of seizures, how frequent they are. Again, this helps us to understand what's the baseline. Is there an opportunity for improvement, or at least to understand when things are exacerbated, that we can recognize those things and act on them. You want to list medications. And another thing that would be important is to list previous medications tried, or medications that have caused negative side effects. The adult provider may not understand those things or be privy to that knowledge, so they may prescribe a medication for you that doesn't work. And so it's important to list those things that you've tried and not have worked out in the past. Same thing with feeds, because now the adult provider has to resume those orders. So we need to know very specific information about the type of gastrostomy tube, the brand, the amount per day, calorie count, water they're intaking, things like that. That's very important because we have to redo all of those orders now that there's a new provider and sometimes now that there is new insurance involved. The other thing when you're on the pediatric side is to have the conversation about transition. Sometimes families and providers, and mainly providers, try to avoid this conversation and they think it's just going to work itself out. But as we know, that's not really good emergency or urgency planning. And sometimes things can happen, such as if one provider on the adult side says, well, I'll just see you forever. Well, what if that doctor retires? Or what if they're cross cover from their other providers that aren't going to be able to see a young adult in their 20s? Or if the hospital they're affiliated with doesn't take your insurance anymore, or is not going to admit a patient that's over 21. So it's important to walk through those things and just have the conversation. It's ideal that this conversation even start as early as 12. It's recommended from the gottransition.org folks that look at transition. So just that repetitive conversation can really make this feel easier rather than an emergency. And then when you get on the adult side, you want to have the conversation again with your adult primary care provider about who is going to manage what. Sometimes on the adult side, there might be a different type of provider that can manage things. Or sometimes the primary care doctor themselves may be very comfortable with managing a condition. So for example, many children with hypothyroidism who are prescribed thyroid medicine are seen by an endocrinologist and pediatrics, whereas adult primary care doctor may feel very comfortable prescribing that because it's a common adult problem. Or hypertension medications is another example. An example where the provider may need to change on the adult side is the management of G-tube feeds. So oftentimes a pediatric surgeon manages G-tubes. On the adult side, that's more done by a gastroenterologist who's an internal medicine, not a surgeon person. Or again, the primary care doctor may be comfortable helping you with that. The other thing you want to look at is your nursing services, supplies, and therapy. There's several changes that can happen, particularly when you change from a pediatric insurance to an adult healthcare insurance. So sometimes the company is just in network with the pediatric age group, and they won't transition their services for adults. Or sometimes the rules change. That's particularly true. I'll give an example of Texas. So in Texas, the pediatric Medicaid will sometimes cover some nursing hours, but adult Medicaid won't. They have to come from home and community-based services plans. So we need to talk about those changes. Oftentimes there's a service coordinator that can help with those things, or a social worker within the clinic. But if you have a service coordinator within the insurance company, they're going to know the most up-to-date rules about these things, and they're the person that you should be talking with. Again, those conversations may happen as early as 12, but certainly by the time you get 16 to 18, you want to be having those conversations about how services may change. So briefly talking about funding supports. There's so many different rules about this, and it depends on where you live. So thinking about private insurance. So for example, in the United States, you can get a waiver of support such that the individual with a developmental disability can stay on their family's plan for private insurance past the age of 26, when normally you would roll off. Medicare, sometimes, the individual can be Medicare eligible if there is a death with their parents, or if their parents are Medicare eligible. And then finally, Medicaid changes. So eligibility is state dependent, but a lot of times individuals have to requalify as a disabled adult, so they continue on Medicaid for adults. And then lastly, each state has its own way of dealing with home and community-based waivers, but a lot of times those can be added supports, such as group home supports or other independent living supports for the individual that are very important. The other thing that the home and community-based waivers can provide is therapies. A lot of times on the adult side, you can't get therapies long-standing, even though that the individual benefits from a quality of life and exercise and healthy living standpoint, that the insurance companies will not pay for that for the adult age group. Decision supports. Decision supports are really important to understand. Not everybody has to have guardianship. We think about that. Well, they can't make decisions or they need support, so guardianship. There's an interim called supportive decision making, where the individual themselves is a partner, and that there's a partnership between their care supporter and themselves, such that they may need a little explanation about things, but the individual can participate in their own decisions. This is part of advocacy for individuals with developmental disabilities because it includes their wants and desires and makes them part of their care team. But this may not be appropriate for everybody, and it may not be recognized by all states. So if you want more information, there's actually a website called supportivedecisionmaking.org, and it gives that state-specific information if you live in the United States. And there's oftentimes a form there. And then finally, next of kin. Next of kin is the default rule. And again, this is state-based in the United States. But what it says is that if the individual lacks capacity for whatever reason, whether that's a permanent disability or, if for some reason they're not able to make a decision for themselves, then the decision-making goes to the next of kin. So that's usually a parent first, then children, siblings, and that sort of thing. But you would want to understand your state rules on that. Going back to guardianship. So I think most people are familiar with how guardianship works. So guardianship states that the individual cannot make ultimate decisions for themselves. They remain like a child in their decision making. They always have to have the guardian to sign the dotted line to give ultimate permission for things. That also not only applies to medical care, but where they live, their finances, and things like that. So it's the most restrictive. There are some partial guardianship opportunities as well, where you can differentiate between some of those decision-making things. However, it can be cost prohibitive for some families, and depending upon the resources of your area, because you have to have a lawyer involved. You have to go through courts to get paperwork signed and update that every year. So if there's an opportunity where the individual can somewhat participate in their decision-making, supportive decision-making may be a way that you can have the support that they need, but the application or the document is free. And so that might be a nice way to help some families. Here's some care coordination things to think about as you transition. And you want to understand this particularly before you leave your pediatrician area and then engage in the new adult care setting. Sometimes the transitions don't happen all at once. For example, your primary care doctor may change first, and then you move the subspecialists along. Or, in the case of Mowat-Wilson syndrome, you may continue to see a pediatric geneticist as one of your specialty teams. But you, again, want to talk about that to make that clear. So you want to understand where are you going to go and who are you going to talk to if you need supplies, if you have an acute visit, where are you going to have where's the best place for emergency care or hospitalization? What information should you take with you? Because again, an adult hospital may be less familiar with chronic conditions from childhood. You want to understand what your funding covers, and you want to understand who are your care coordinators. That may come from the clinic, insurance, or waivers. And it's nice to have a point of contact if you have multiple care coordinators so that you can share that information with everybody. And that way, if they need to communicate about a missing link, for example, getting a wheelchair is a common missing link, then we want a point of contact so that everybody can communicate in the most efficient way possible, though recognizing that efficiency is hard to maintain in care coordination during this time. How to think about supports for community living. So oftentimes individuals lose their school supports where they go every single day and they've gone there for 21 years. And then you graduate and you have to think about how do we rearrange our life. A lot of people have had to do that this year with COVID. So it's almost like a foretaste of what that would be like to have to stay at home and how are you going to manage and everything that needs to be taken care of. So what are the home supports on a daily basis for activities of independent living, medical needs, safety, or even growth in that. So are there adaptive skills that the person can learn? So thinking about that, thinking about their daily medical needs, who's going to provide those things, who's going to monitor for concerns, and then finally, how is the individual going to participate the most in their community and in their environment? Does that look like going to a DATE program? And you may want to ask at DATE programs, is there a nurse there if there's a medical need? How do we maintain safety, especially during COVID? What are the opportunities for employment? I think this will be a big need after COVID vaccines and things open up again. I think that engaging again in our community is going to be something that may be challenging for people that have just gotten used to staying at home as well. So that's a lot, and sometimes it can be very stressful to think about those plans. But just as Rome wasn't built in a day, our preparation for transition isn't built in a day or in a visit. It happens through relationships over time and through preparation over time. So if we think about lifespan transition, these are some tips. And I take care of patients with a variety of levels of intellectual and physical disability. So I recognize that not everybody's going to be at the same place at the same age, and that's okay. That's part of what makes us unique individuals, and it makes it fun because you have to find that little spark of thing that somebody could learn and somebody could be more independent in. So what I say is nobody is too early to have a medical summary, and that might be useful when you switch to different providers or go to a different location. You want to start understanding what your supports are from your waivers. For example, in Texas, they're the biggest state waivers. You have to be on the wait list for 15 years. So if you start that at age 20 and you're wanting to have post-high school graduation supports, it's very difficult to start that at that time. So good to start those as soon as you recognize that there's going to be a lifelong support need. Who are your backup caregivers? I've had family members that were caregivers suddenly pass away. And so overnight they had to do this handoff, and they would call me, for emergency medical summaries and care supports. And I say, I'm sorry, but I don't know what went on from day to day. I certainly can give you the medical summary, but this is quite a challenge if there's one sole care provider and there's not a handoff backup plan in place. And then again, reaching up to adolescents, you want to start talking about those transition plans with your provider. You can start talking about what decision-making supports we'll need. Sometimes on the pediatric hospital side, there may be a medical legal liaison that can help with some of those documentations needed for guardianship. You want to understand how your insurance plans are going to change. And then with high school, especially in the special education departments, it's required of them to include a transition plan as part of their IEP or individualized education plan. So you want to talk about that. Sometimes they even have vocational support liaisons from your various state or local support areas that meet with the school. And I find a lot of families don't know about that person, don't know about that relationship, and that they could be already receiving some of those vocational supports as part of their educational plan. And then you want to start talking about safety. So this may include sexual safety, relationship safety. As we all know, and it's been very sad and tragic to see the biases that happen in our country in the United States during this time. One can only imagine what it would be like to have an unrecognized individual with an intellectual disability or behavior concern that was wandering in the streets, and what that might happen. And sadly, we've had some of those scares with our patients. So thinking about safety, thinking about safety for elopement for an individual, thinking about how you would give them a medical alert bracelet or something like that, that would get them to safety is an important thing to think about as part of this planning. And then finally, in adulthood, we need to think about the sad reality that that our children may outlive their parents sometimes, or their caregivers may not be able to take care of them on a long-term So thinking about what those long-term plans look like, thinking about that financially are all important things to do as we think about the adult and beyond. So again, this time can be very stressful. I've had families cry when they have their first visit. I've had them rejoice and feel very comfortable. We're seeing that more and more as we've been practicing how to do this well. And then I have some families say, oh, you know, we never have to talk about sexual safety or things like that because they're just never going to be exposed to that. So we can never say never. We want to make sure that we provide and think about the things that we can to make a holistic plan for somebody. I also say everyone grows up in their own way. So even when you may continue to need care supports, you may see the individual wanting a little bit more privacy or exerting their will in a new way. And all of those signs are normal, normal ways that everybody adults. So we may see them manifest in different ways depending upon the individual's personality and their abilities. So when I think about wellness for a young adult with IDD, it's multifaceted. And here's some tips or things to think about for each one of these circles. So their physical health. So we want to ensure that they have access to appropriate care and optimize chronic care conditions. This may include a backup plan. So if you have seizure disorder, what is your plan if there's an increase in seizures? Do you have a backup medication? You know, who do you call, etc. In the community, where are the places where the individual has a sense of belonging, connection, and purpose? COVID has been a challenge to this, but also is post high school where they've known those friends for all of their life. And now we're disconnected. So that can be pretty difficult. Emotional health. So this is self-recognition of our emotional needs as well as the caregiver's ability to recognize emotional needs. Sometimes a behavior change or aggressive behavior or just out of sorts can be a sign of a physical concern, an emotional concern. So how do we discern what is going on when those behaviors are telling us that something is wrong? Close relationships are important for everyone. So what does that look like with friends, with family, romantic relationships as well? And then thinking about education and employment. What are appropriate post-high school supports for work and school, and home responsibilities for the individual. Everybody can feel a sense of purpose and belonging, and home responsibilities may look like putting napkins on somebody who's in a wheelchair and rolling their wheelchair to the table so some other brother and sister can pick them up and put them on the table. That allows the individual, that small act, to feel like they're part of the family and have household responsibilities. And self-identity and self-efficacy. So appropriate independent choice. And sometimes we make a choice for somebody, or present a choice that is a safe and has bounds. Like, do you want to wear the pink socks or the blue socks today? Right, that's still a choice, and somebody having to make an independent decision for them. And participating in decisions as much as they can. So it may be like, do you want to look in your ears first, or do you want to listen to your heart first, is a medical example. This is for all of the caregivers. So this analogy has been taught to me by some of our parents. And that's when you get on an airplane, if we can think about when we used to do that, they tell you about the oxygen mask, that first you have to put on your own oxygen mask before you assist those around you. And I've flown with small children, they remind me as a mom that I need to put my mask on first, even though my tendency would be to take care of my son or daughter first. So I'll give an example of, I had a patient who had some behavioral concerns, who had autism and was very extremely nervous. And I got talking to the mom, and I asked her, like, are you taking care of yourself? Do you have a doctor? And she said, oh, well, my diabetes is very out of control and I haven't been taking my medicine. And I thought to myself, so probably the most stressful, worst thing that could happen for that individual would be for the mother to get very sick and have to go to the hospital or have complications where she can no longer take care of her son. So again, taking time to take care of yourself allows you to take care of the person that you love and who needs you. So with that, this is from the caregiver.org. This is wellness for parents and caregivers. So again, considering personal, physical, and emotional health, following up regularly with your doctor, exercise, and healthy eating are some of the best medicine that you can give yourself, and making sure that you have positive relationships in your community and that you can ask for help when you need. So that's recognizing when you need help, which sometimes is hard, and who are you going to ask about that? Regular rest and refreshment. So sleep is important. Sometimes I know that individuals with developmental disabilities have irregular sleep patterns and need some support at night. So that's a reality, but how do you get breaks where you can have good sleep and time off and rest so that you can engage in some of the most important work that you can do? And who's your support team? Do you have a handoff plan? You may even want to show the handoff plan to other people to make sure that it's understandable before you reach a situation where somebody would need to take care of the individual with the developmental disability. Also, many organizations have peer support groups where caregivers can just talk about their shared experience. And I know there's multiple blogs or online chat things that also are great for this. Long-term plans. What are your plans when you can't be the caregiver anymore? Do you have an up-to-date will? Do you have a letter of intent for those things? Have you thought about your finances and how I know there's special needs trusts also that can help individuals with disabilities. So those might be things that you can set up for your son or daughter for the future. The wellness of the person that you're taking care of. So it's important to understand how times of your loved one's unwellness affect you. So again, I think sometimes it's harder for an emotional concern than a medical concern that feels fixable. And I think sometimes I've seen a lot of caregivers feel and articulate, I never want this to happen again. This can't happen again. And recognizing how are we going to cope when we feel like that is important. And how do we heal emotionally certainty or a crisis or an exacerbation. Perspective is also important. So remembering it's a marathon and not a sprint. Sometimes we have to let go a little bit. Maybe our house isn't as clean, or, maybe that lotion didn't get on the rash for today, something, and say like, it's okay, and if we forgot it today, we're going to start tomorrow. There's obviously some things that are essential that we can't forget. But there might be some things that are less essential that it'll be okay if we forget. Remember that you are valuable, but you're not the only person that can help. And again, let people be part of that care team so that the individual with developmental disability can have multiple experiences. That's what makes us rich as humans, that everybody's a little different. And it's also okay to say, I need help. And to do that, hopefully, before we reach crisis point. Obviously, there's sometimes when we can't do that well. So those are the end of the things I wanted to share. I'm going to stop my share and hopefully have a little bit of time for questions.
Does anybody have any questions? I'm not seeing any in the chat. There's a few comments regarding Special Needs Trust. Okay, here's one. You mentioned this a bit earlier, but I wondered if you could talk more about the lack of therapies for adults.
Sure, I'm happy to help out with that. Again, it's difficult to talk in specifics because it can be state or area dependent. So one of the concerns is that I'll just speak from my experience. Number one is finding the right providers that can take care of adults. So for example, if somebody has a behavioral concern and really needs behavioral intervention, finding a psychologist or a behavioral support person that really understands how to interact with families and individuals with intellectual disability can be a challenge. The second challenge to that may be a funding concern, like payment for Medicaid insurance or what have you. So those are the two challenges that I oftentimes face. And then many insurance companies, and I think this is more universal in the United States, go based upon Medicare rules for things. So for example, for physical therapy, for everybody, for us all, that we have to have a new or an acute need, such as my back started hurting last week, but if we have chronic back pain, that's not something that we can continue to have physical therapy, or there might be some physical therapy goals that we have to meet, and then the service will be done with. So physical therapy, for example, for range of motion for an individual that has spasticity or contractures won't be a covered benefit for most insurance companies in the adult setting, because they're out of that developmental time period. Sometimes if you have a home and community-based service plan or a waiver, that you can add those to your budget. And that's really why you want to pursue those opportunities and sign up for those wait lists early on. But it's important to understand that the eligibility for services, as well as the providers familiar with helping individuals with a developmental disability, can be limited on the adult side.
Okay, and another one, what if your community doesn't have a day program that takes adults in diapers?
That is a challenge. So probably for that, I would ask, number one, if you have a home and community-based service that you can work with, that is the number one. The local ARC is a national organization, so your closest affiliated ARC may have some resources for you. And then oftentimes there's state-based developmental disability councils or services. So a lot of times the way those monies are distributed at the state level, they go to a county or a group of counties. Like in Texas, it's called the Local Authority of Intellectual and Developmental Disability, but it could have a different name in a different state. So that's one of the things that's hard, is that it's different in every state. But those local organizations oftentimes have developmental disability services. The other creative way that you might handle this is to meet with a couple of parents, maybe parents that you knew from school or other interest groups, and think about how to develop a day program or something like that, where you could hand off responsibilities. I've also seen that people have done Zoom meetings, and for individuals, especially since their day programs have been closed due to COVID. So thinking creatively about how you might do that. Sometimes Medicaid will pay for a provider, so that could be a family member, a cousin. I find that many of my young adults with disabilities love hanging out with young adults. So that can be a positive opportunity for them to learn some independent skills and have some time with some young adults.
Okay, and is there a way to determine how much a group home would cost if we pass away or aren't able to care for our son anymore? Again, I would think that depends on where you are.
It depends on where you are. Oftentimes, again, home and community-based services can help you out with that within your state. So most states have a page on that on their Texas, so for example, like the Texas Health and Human Services. So I would look on your Health and Human Services page. Additionally, you could call 211 in your local area if you didn't know how to find that information. But talking with those home and community-based service or waivers, that's who could help you to determine that.
Okay, and if your child is on your private insurance through your employer, if you get guardianship when they turn 18, will the insurance companies generally allow you to keep them on the plan?
Yes. So that's actually a federal issue. So as it stands right now, everyone can stay on their parents' insurance until they're 26, or if they get married or get their own insurance. If you have a son or daughter with a disability, that's a dependent living in your house and sort of income dependent upon you, then you can sign a waiver. So ask your benefits person within your company to get you a waiver form that's going to be an adult dependent waiver. The physician has to sign off on that. So I would have to say they have a genetic condition that they were born with. They're dependent for all of their medical care as well as their activities of daily living, such as dressing, bathing, etc. And it's a permanent condition. And so I just sign my name to the bottom testifying that that's the case. They submit that back to their benefits office, and then that allows the individual to remain on your private insurance until you don't work for that company anymore. If the company, I think this is the rule, if the company were to change insurance plans, then that waiver continues. However, if the parent switches companies, I don't know that there is a protection there that the new insurance plan has to pick them up. But I may be incorrect about that. That's the only thing that I would not be certain. However, it protects you as long as you are on that insurance plan with that company. And that's regardless of guardianship. It doesn't have anything to do with whether or not you have formal guardianship.
This one, my son has Barrett disease and takes his medication through his G-tube. I seem to be having a problem getting his medication each month, having to go to different pharmacies because the primary pharmacy cannot get it from the manufacturer. How do I get help getting needed medications for my adult IDD?
Oh, that's hard. So if you have a Medicaid plan, and by the way, you can have both private insurance and Medicaid. You can have both as an adult with IDD. I would first start with my Medicaid plan. If there's a service coordinator or somebody like that you can talk to about that concern, a lot of times they have a pharmacy component that they either contract with, and they can help you to determine where to get that medication and approval and things like that. There's also sometimes like e-script pharmacies that deliver from another company. You just have to find somebody in network with your insurance. But I have mail order. I have some families get mail order pharmacies, and at least that helps with that concern of not getting the medication monthly.
Okay. In your experience, is there a good time to think about transitioning an adult child into full-time residential care as parents age? I have knowledge of a number of families where it was a crisis.
Mm-hmm. That's a great question. So there's just so many things. There's so many individualized things. I've had families where the parents probably wanted to transition the individual into a group living situation, but the individual did not want to go. And then the opposite, where the family said, well, we'll just keep them until we can't anymore. And that can't anymore happened very suddenly. So if you have the opportunity to participate in respite care, again, this is in non-COVID times, and I appreciate the difficulties for right now. But if you have the opportunity to participate in respite care, then the individual can go and sometimes stay in a group home situation, like for the weekend or something like that. And for them, it's like a little vacation or something. And so it's a 1 or 2 days, or even a day program in that area where they can kind of get used to it. Then that's great. But I think a lot of the reasons why people transition into a long-term care living situation for the individual are several-fold. So a lot of times it's behavior concerns, that they cannot manage the behavior in their home with the supports that they have. And they just feel like they can't do that anymore. Sometimes it's physical concerns for the family. And then sometimes it's for the individual. The individual just likes to live in a group home with other people his or her age. And it feels very adulting for them. And maybe they go home on the weekend. So I think you have to kind of see who are your supports around you, who are your backup people to give you some respite. You can consider using it like as a little vacation time or weekend getaway for the individual to get used to some of those situations, to see how it goes. And then walk some of those transitions through, and having a transition plan, like what it's like when you go and stay with your friends at the place, like very positive frameworking of those times, so that the individual can get used to those situations.
Okay, and the last question I see here, if you are self-employed and retired, it says, will they go to I think it's supposed to be Medi-Cal. They're in California.
So if you're, so individuals can qualify for Medicaid by themselves. So over 18, well, I'm going to speak Texas, but you have to have adult disability determination at age 18, and that qualifies you for Medicaid as an adult. And so that determination as an adult with a disability is a federal Social Security criteria that they can't work, either for cognitive or physical disability. So they can continue with the Medicaid as an individual once they turn 18. If a family member receives Medicare, or the family member, the parent passes away, then the individual can also be eligible for Medicare. So they would have Medicare and Medicaid. However, sometimes for some states, the money is also important. So how much income does the individual get monthly? If they get SSDI benefit, so SSDI benefit is what you get at retirement, or if the parent worked and they passed away, so SSDI benefit is the death benefit. Sometimes whatever that amount is over the amount that they're allowed to have in order to be with Medicaid. Does that make sense? So we have to do a little bit of a recalculation in order to get the money to work out for their supplemental income. And a social worker would be able to help you with that, or your like a local authority person, or like a waiver person could help you with that. The Social Security office sometimes can help with this case management, but if you have the opportunity to work with a social worker that's clinic-based, they may be able to be more sensitive to all of the inner workings of this. It's quite complicated, but at the end, know that if somebody is a dependent adult, they can qualify for Medicare from the family and Medicaid as an individual, as an adult.
Okay, there was one question that was in Spanish that I translated, and it says, is there any period when crises are going to stop, or will it be for life? That one is
that one is very hard. I've often told my patients themselves and their families that we all wish that, whether or not we have a disability or we don't, that things that are hard come. And I think that it's important to realize how you approach those things. I think there's some ways that we can plan and to intervene upon things from a medical standpoint, or sort of be prepared for those things. So what do you do when you have a fever, where you have a cough, when you get pneumonia? How can we prevent that? Is there any way? So that, I think, thinking through that those medical issues is something to do regularly with your doctor team, to talk about those preventions strategies if they're available, is one thing. And again, I think that as a caregiver, having peer support and having emotional support for your needs and how you face hard situations, and just some tips to make sure that you're coping the best you can with hard situations is important for your self-care, as well as the long-standing care that caregivers face.
Yeah, self-care is extremely important. Mm-hmm. Okay. Thank you so much, Dr. Fremion.
You're so welcome. I wanted to mention one other resource that you can look up. It's called Trauma-Informed Care. And what trauma-informed care is understanding that there are certain things that are very stressful for an individual who may not understand all that's going on. But there's ways that we can modify their experience so that we don't lean into those things that make them feel unsafe or uncomfortable. So there's many resources You can just search trauma-informed care for individuals with developmental disabilities. And I know that there's some modules and training that can be helpful. Those things were very eye-opening to me, just about my approach, explaining things, taking a little bit more time before I jump into an exam and get in somebody's face, which as people that understand what's going on, it's not stressful. But if you didn't know it was going on, or if you had been held down for a blood draw or a shot or something like that before, well, as soon as the doctor approaches you, that could trigger all sorts of things. So those ideas are really important for families to understand about their loved one and communicate to their team of caregivers and their doctor.
Okay, thank you so much.
Thank you. Bye-bye.
Well, everyone, that ends our 4th session. I'm so glad for everyone that was able to participate on the Zoom. And for those who weren't, we've got all of our sessions up on YouTube, except for Dr. Charney's, which will be up later in the year when her research is published. We thank everyone for attending. We will be in the next few months looking at planning our next in-person conference, most likely for 2022. We'll keep you updated on that. For our U.S. families, I hope you all have a wonderful Thanksgiving holiday. And everyone, please continue to take care of yourselves and your families and stay safe.